Good afternoon, everyone. Good evening in Pakistan. Today, our session is this is the follow-up session about renal stones. Dr. Masud presented about stones last week, and today we will discuss all the cases. So over to you, Dr. Masud.
Okay, so last week I briefly described the etiology, different type of kidney stones, and just brief description of how to manage that, medical evaluation and treatment. I think that more we're going to learn when we basically discuss cases and learn from each other. I'm not an expert. I don't think that anybody can claim that he or she is an expert in kidney stone. Our knowledge, at least my knowledge, is evolving. Recent to some, I managed to read something and also managing patients. But again, I'm learning, and I think that our colleague in Pakistan, they deal actually more burden of venous stones every day than we do share, and we're going to learn from their experience also. So let me start some cases. I have a few cases, actually just an appetizer, so we can start the discussion. So Dr. Farooq, can you make me host so I can hear my slides? Okay, good. Can you see that?
Yep.
Okay. So this is a patient. He is 61-year-old male with the history of recurrent calcium oxalate stone. He has had multiple lithotripsy in the past. He used to come to me, but lost to follow-up in 2010. Before that, he had multiple lithotripsies, and after that, everything was gone. He said he was cured and started coming. So again, he had stone came back, and he was sent back to me by urologist in 2020. And so his when he came back, this was his 24-hour urine. Volume is good, not bad. His supersaturation with calcium oxalate stone was high, so it looks like he had, as we know that he had calcium oxalate stone. So oxalate level is good, not high. His calcium is a little bit high, urine calcium, again, not too bad. The citrate is very low, 279. The normal is 300 to 1,000. Actually, we like to see at least more than 500, so he's pretty low citrate level. Because he has very acidic urine, so his risk for calcium phosphate stone was low. You can see that supersaturation with calcium phosphate is very low. Similarly, uric acid. So this is a relatively simple case. This patient's main problem is low citrate level. Doesn't have metabolic acidosis. I don't think so otherwise. So basically, he was put in on potassium citrate, high dose. High dose means that I put him on 30 milliequivalent twice a day, and keep checking his urine pH and potassium, and kept his potassium 6.5 range and his urine citrate. I'm checking again, but I'm hoping that it will be in good range. He's not very keen of doing 24-hour urine, doesn't do one couple of times. He messed up that, so we didn't have any repeat. But after last lithotripsy, which was about more than a year ago, his recent ultrasound or CAT scan didn't show any kidney stones. So hopefully he will not form any new stones. So basically, this is a common patient, relatively simple to manage, and actually very rewarding. This is a common patient that if you appropriately diagnose, and his urine sodium used to be high. I told him that we need to cut down his salt intake. Otherwise, he's doing fine now. He's very happy that he didn't feel any pain, and urine was no blood. has no signs of any kidney stones. So this is one of the simple ones. Any comment or anything on that?
So here we actually want to discuss the metaphylaxis, the preventive things that we would advise to this person so that he does not have recurring stones, right? And all the time, or at least more than once, he is known to have calcium oxalate stones with a lower citrate and urinary citrate level. This is a very common presentation in our setup also, where you have lower citrate levels. And we cannot exactly pinpoint the reason why these people have, certain people have lower citrate levels in their blood and in their urine. Hypocitraturia is one probable hypothesis is that if you consume a lot of oxalate in your diet, then this oxalate and citrate in the gut has some, I think, some competitive absorption thing. So if you have consume more oxalate, then you have to get rid of more. You cannot absorb more citrate. I cannot exactly recall what is the exact pathophysiology behind it, but that I'm sure that in more oxalate in your diet will lead to hypocitraturia. And this we have documented in a large population. In pediatrics, what we did was that we measured 24-hour urines of siblings who did not have stone and compared it with those children who had stones. So the idea was to look into dietary risk factors that would lead to hypocitraturia. So if that same sibling would probably be consuming the same diet, and we found that those children who did not make stones also had a significant number of them had hypocitraturia. So we thought that the main one of the main cause of these recurrent stones is hypocitraturia, which is probably related to diet. There could be some genetic predisposition for some people that when they are exposed to this hypocitraturia, they do not, they tend to make stones and others don't. And giving them citrate, advising them to avoid oxalate, which means less tea, less spinach and leafy vegetables, chocolates, and consuming more of limes, citrus fruits, would help them increase their citrate levels and then subsequently this recurrence of stones. So
okay, very informative. So one more thing about low citrate, a couple of things there. Some people who have diarrhea or whatever reason, if they have low potassium, low potassium increase citrate absorption in the proximal tubules, and it has low citrate level in the urine, and that increases the risk for kidney stones. The other important thing is that nowadays one of the medication is very common used for seizure, headache, migraine is called Topamax or topiramate. This medication is very commonly used for that. And this medication causes metabolic acidosis actually by two mechanisms. Some describe that because of increased absorption, like a type 4 type of RTA, increased absorption from the proximal tubules, and the others say that probably caused distal RTA. But anyway, very common cause of metabolic acidosis, and that causes kidney stone. So much that, I mean, it's not, but a couple of neurologists were busy actually. When they have patients start on Topamax, they send patient to me just to monitor their bicarb level or keep whatever need to be done, because that can lead to kidney stone. Is so common. I will describe another case today. A patient who is on zonisamide, which is typical almost similar medication. It caused a lot of kidney stone. I'm not sure 100% that medication causing that, but that medication is a same thing, like very low citrate level can cause that. It's like is what almost like a carbohydrate inhibitor. So that's a medication need to be kept in mind when patient has metabolic acidosis and very low urine citrate level.
Yeah, thank you for bringing this up. I think this topiramate or Topamax, that is becoming increasingly common. I have two young patients. One is actually a kidney donor. So single kidney, now stone in the kidney, and because of the migraines, had been on Topamax. So that was the factor identified. So we stopped the medicine and we hope that the patient doesn't form more kidney stones, because once we stopped the medicine and we did some biological studies, the 24-hour urine, it came back actually normal. So patient had stones, the 24-hour after stopping, few months after stopping Topamax, it came back normal. Whereas when she was taking it, bicarb was low. So probably the same mechanism. And so far, she's doing okay. She was able to pass her previous stones, and we haven't seen any new stone on the yearly CT scan, and her next appointment is, I think, coming up in a couple of months. So that is a risk factor. And sometimes, looking at the med list becomes so important for us to find or identify the etiology, because a lot of time, a big part of our job is to do the chart biopsy. So thank you for sharing that perspective.
Biopsy.
Well, I call it chart biopsy. Whenever we get the AKI consult, you are in the EMR and all you do is chart biopsy, because this is how you find why a patient got AKI in the hospital.
Actually, last night I did a chart biopsy, some of the cases I'm presenting, so I found some new information. You're right. The other thing that interesting, that low oxalate diet. Obviously, some diets are controversial, some are very clear, like spinach is any doubt, probably the highest oxalate content of any diet. And nuts have other, but tea and coffee is the controversial. One of the cases I'm going to present have very high urine oxalate level, and tea is always question, tea and coffee, whether risk or not. I think if you go by older studies, a 30-year-old and other, they say that tea is a risk factor for hyperoxaluria, but recent studies unanimously actually describe that tea and coffee, they are not risk for calcium oxalate stone because they act as a diuretics also. So they do not cause any risk, but anyway, still a little bit controversial. I typically do not ask my patient to restrict their tea or coffee intake.
May I?
Sure.
Tea is English tea is different from the chai that we drink here. When you put a lot of milk and cook the tea in the milk, the doodh patti that we're used to, it is I don't know if they have these recent ones that they said that I've read those especially for coffees, and the iced tea that they consume is not the same as what we consume here. The blend of tea that we cook in milk, a lot of milk, and the more you have skimmed the milk, the better the tea is. So that probably has something to do with it. And also with the problem with the tea is that since milk is very expensive in our rural areas, so and that is probably the only thing that is available in the villages. So what they do usually is that, one of the child, I gave him some sedation, and he went through a surgery and he woke up. He was NPO for many hours. He was very hungry. And I asked him, I said, give me one of your desire. What do you want to eat? And the only thing he wanted was chai and roti. That is one of their staple diet. So consuming that much, and the reason why they drink that much chai is that they cannot take milk and roti. It is, the mother has to make it for the whole house. So she mixes a lot of water, puts little bit of milk and gives it a flavor and a lot of sugar, and then the whole house can dip just a piece of bread in it, and they feel full. So if you take that as only your breakfast, then probably we have seen that. Yeah, in metropolis like Karachi, there are shopkeepers who are in a habit of consuming 20 to 25 cups of tea every day. And that probably is a risk factor. And I have seen quite a few patients who were consuming a large volume of tea, and when they had restricted it to 2 or 3 cups a day, then they were okay.
Okay, great. So you're talking from experience, your personal experience. So that's very important. Basically, one thing is, theoretically at least, when they do that doodh pati, when they mix calcium and milk with that makes calcium oxalate mixing, and that prevents any absorption of oxalate. So that actually doodh pati is better than like black tea. Taking that with black tea without adding milk or cream, that increases the oxalate absorption and goes to the urine. But again, you're right. If you're drinking that much tea in a day, almost nonstop, so then definitely you are increasing your risk for calcium oxalate stone. Absolutely. Okay. Please keep checking in chat any questions so we can talk now. But if none, then let me go to the next patient.
Yeah, I think I would probably ask our other colleagues to share their perspective as well. Yes. I know I can volunteer Dr. Zahid Farooq if he has any case or something.
No, sir, none. Thank you very much for inviting me, but no case today.
Okay.
Okay. So this is a patient. I don't know why he went to. Went to primary care doctor, sent because his PTH was a little bit high, and he sent to an endocrinologist and who did a 24-hour urine calcium just to check whether he has. So this is his recent 24-hour urine calcium, which is not bad. So his only risk is low citrate level. So hopefully he would stay off forming kidney stones. Okay, so this patient actually just received consult. Actually, I have this in front of me, it's copy also. So this patient is a 54-year-old male referred by my primary care doctor because his creatinine has been going up recently. And it was about 6 months ago, it was 1.67. A year before, that's 1.39. So slowly increasing. He has significant past medical history, 2011. He has pancreatic mass, underwent surgery and chemotherapy. He also diagnosed as the familial adenomatous polyposis, pancreatic polyps or rectal mass, and he has a surgery and ileostomy 2021 and second Whipple procedure. He also had abdominal aortic aneurysm dissection, repair, and had endocarditis and aortic valve replacement, and has cardiomyopathy. So 54-year-old guy, he's pretty sick, okay, unfortunately. So he said first time 15-year-old ago, he had lithotripsy done, and now he is getting lithotripsy almost every year because he's forming too many kidney stones. He never had metabolic workup done and never referred to a nephrologist by his urologist. So it's not like everything is perfect here. So we have our limitations also in taking care of the patient. So recent blood work, creatinine 1.64, sodium is 138, potassium is okay. Doesn't have metabolic acidosis. So labs are not serum level labs are other than increased creatinine is not too bad. So I had him done 24-hour urine twice just to be more specific. So we can see that his urine output is very low. You can see that. He said because he tries to drink, but because of colostomy, he loses all the fluid through colostomy and end up making very low urine. And you can see that his supersaturation from calcium oxalate stone is very high. And very low urine citrate level. Urine pH is very, very low. And supersaturation for uric acid is high. He has very, very acidic urine. He doesn't have much calcium in the urine, which is normal range, not oxalate. Very low risk for calcium phosphate stone. So basically, he has high risk for calcium oxalate stone because of very low urine citrate level and very low urine pH. Okay, so this is for discussion. What you suggest on this patient? So obviously, he would need high dose of potassium citrate. Okay, citrate to. Any suggestion what you do about this fluid-wise? I mean, he said even he takes more fluid. I mean, his urine output will not increase in this case. I had couple of patients who, for whatever reason, because of cardiomyopathy, other reason, they are not supposed to drink a lot of fluid. They have other risks. So what I try to do, whatever other risk factor I could decrease them, I would do like try to decrease calcium as much as I could, give a high dose uric acid, citrate. So I think all I can do, give him more citrate. I don't know how that would be absorbed, how much there would be. And I think I would check uric acid, serum uric acid. I don't know how is that, I forgot. I would check that. Maybe he's a little bit high, giving allopurinol, so actually uric acid not too bad, so that will not help. Sodium is not bad, so I think all he needs very high dose citrate. And he's following a lot of kidney stones because he has very high risk for forming kidney stone. Do you deal patient like this? I mean, any idea, any suggestion what to do with them?
This is a really tough one. No, I have quite a few patients on colostomies or water restriction, but this acidic urine with this low citrate, and there's nothing that you can do to increase the urine volume. This is a tough one. No, I'm sorry. I don't have any suggestion.
I mean, the chat room, I think, is another bad suggestion. I mean, I'm suggesting that is it possible to have IV fluid on this patient, IV bicarb? I mean, if forming this much kidney stone, I think I have to look into it, whether that is possible or not. I mean, there are some patients I have who have, for reason, very, very low magnesium Gittelbert syndrome. And they go to actually twice a week for magnesium, actually. IV. So maybe this patient, I would try that if that's possible, to get some IV and bicarb, and because bicarb level is not low, but you can, I don't know whether potassium citrate, because kidney function is not normal, how much potassium citrate you can have. So alternative is the magnesium citrate or calcium citrate or sodium citrate. Sodium citrate is commonly we give, but that has sodium in that. He has some cardiomyopathies. But I will look at it, and I think very good suggestion. I was thinking about, but I think one more recommendation, see possibility of if you can go to, if not twice a week, once a week for IV bicarb or IV fluid. Otherwise, he will keep suffering. Patient go for infusion center because of cardiac reason, other reason, chemotherapy reason, like once or twice a week too. And this is also important, is comorbidity. I'll look into it. That's thank you. That's a good suggestion.
So can I ask one more question,
Sure.
Just to clarify? So anatomically, so patient has colostomy. So where is the connection? Like in the gut, how much of the gut is taken out, and does patient have shortcut syndrome? Is that the main problem? Like, because volume is the primary driver here, right?
Yeah, I mean, basically, I think he has a pretty extensive. I think he is some ileostomy. I mean, ileum also, and some part of the gut. I mean, that's absorbed. So basically, the small intestine where the most absorption happens. So that's why he's not able to absorb much fluid. He said he will try to drink, and probably that's causing all the acidosis.
Yeah, because I have a patient who, of course, the primary problem is not stone. The primary problem is the recurrent episodic AKI with hypokalemia, and she has total colectomy done, and her part of the small intestine is also removed, but her small intestine is connected end-to-end to the rectum. So she loses a lot of fluid because of gut motility problems, as well as the way the anatomy is. So logistically, just to add, we have a home visiting, the home infusion company. So they go to her home every Wednesday. She gets 1 liter IV fluid or 2 liters, whatever we decide. And then if her labs are bad, then some weeks she gets twice a week, some weeks she gets once a week, to keep her out of the kidney failure. Because if your end goal is to keep this patient out of kidney failure from stones, then if the volume is a primary problem, you have to either give by mouth, by IV, or by PEG tube or something. So there must be something more than what she's doing right now. Please.
IV bicarb, I have intrinsic problem with it. It burns the veins if you give it through peripheral veins. And I've had very bad experiences with those phlebitis and those craters that they form, the alkali burn, if it just, a little bit of that fluid extravasates. So would you consider giving some oral bicarb like sodium
Okay,
bicarb?
let me, because we use so much IV bicarb, you have no idea. Okay, very much. Okay, so basically, and we never had any problem. Okay, but it all depends on how much bicarb you're giving in the fluid. So basically, just for, I don't know everybody knows, but just to see how bicarb we give here in our center. So IV bicarb is given by 3 ways. One is given by mixing with the D5W, okay, dextrose. Yeah. So in that case, if you want to make it isotonic fluid, like isotonicity is like close to 290, like a isotonic, like a normal. So you give 150 milliequivalent of bicarb in 1 liter of D5W, that isotonic. And if we have a patient who is a little bit hypernatremic, so we want to give hypotonic fluid, we cut down the milliequivalent of bicarb to 100 or even 50 in 1 liter of dextrose water. If patient has high blood sugar and we don't want to give patients D5W, and we used to give half normal saline. So in 1 liter of half normal saline, we give only 75 milliequivalent of sodium bicarb. If you do more than that, you can make it hypertonic, and that can increase the risk for any vein problem. Okay. And third way, which we actually default, last year I actually approved that. We gave almost everybody in distilled water. So 1 liter of distilled water, 150 milliequivalent of sodium bicarb. That makes it isotonic. Sometimes we need to give more. We don't want to give too much fluid. Like sometimes we give 200 milliequivalent of sodium bicarb in 1 liter of distilled water or D5W. Even then, we never had any case where have any problem with this. You're right. That's why sometimes people give like IV push the bicarb. That is not a good idea. That can cause a lot of that vein problem what you're describing that. So as long as your tonicity is not very high when you give fluid, you have no issue. We give tons of like if you see my patient in hospital, at least 5 or 6, if not more, are getting bicarb right now, and we never had an issue because if you keep on your tonicity or dilution at appropriate rate.
So in here the bicarb. I think there is in 1 ampule there is
50.
50.
I mean, we have 50. Maybe you have different.
I think it's same over there too, my experience.
50
I don't know if
milliequivalent in one
pediatrics have different, but 50 is in one.
We have 25 milliequivalents bicarb drips.
Okay.
I mean, ampules in Pakistan. But my question is that, when D5 water is already isotonic, if you add bicarb to it, it's going to be hypertonic anyways.
No, D5W basically is like a water. When he goes to patients, it's just totally, within minutes, it becomes water. It's dissociated, it becomes water. So D5W is equal to water, giving in water. So
I mean, if you look at the osmolarity of the fluid that you're giving,
yeah,
it should be isotonic. You cannot give hypotonic fluids.
No,
you'll cause hemolysis.
Theoretically, if you have like there is the D5W also has tonicity. If you add to that, theoretically it increases your tonicity. But practically, yes, if it goes to inside the patient's body, D5W within minutes dissociate into water. And if you check the osmolarity of the serum osmolarity after a patient given D5W and bicarb, you will see the osmolarity is not high.
So here there are two things.
Yes.
The osmolality and tonicity. They are two different things.
Now you're making complicated. Okay. Okay, no, go ahead, but this is interesting.
Yeah, it is hypotonic, but isoosmolar.
Okay.
It can be in any combination. Hypertonic and isoosmolar, hypertonic, hyperosmolar, hypotonic, isoosmolar, hypotonic, hypoosmolar, depending. The only concept here is that when this fluid stays in the serum, when you infuse it in the blood, if it stays in that same composition in the blood, and then the tonicity is what drives water across the cell membrane, and the osmolality is just the number of osmoles. So if you have increased that tonicity by dextrose goes into the cell immediately, and the tonicity behind that fluid that decreases. So it becomes isotonic then, what Dr. Avais just said. That after giving it, after a few minutes, it becomes the same as water.
Yes. So for your own, you can check that. If you give patients with the bicarb, with the D5W, and check patients' serum osmolality, you will see that it will not be like which theoretically would be, it will be like as you give in water. That's why we give like tons of D5W with bicarb, or just like, because I work in ICU, it's very commonly we give, and never ever had issue with veins, any problem with that.
Interesting. Because with the same thing, with much less bicarb in a liter of fluid, we have had problems. So I don't know, it could be just us.
No, it doesn't. Just check serum osmolarity in that case. See if your serum osmolarity is higher in that case. I practice that if patient has metabolic acidosis and patient has a little bit hyponatremic, we commonly give 200 milliequivalent of sodium bicarb in 1 liter of D5W or distilled water, which is hypertonic, and even then we don't have any issue. Yes, when we give this very commonly, and I'm very against that, even with the cord, when people give like a bicarb push, okay, that is a problem. That's a very high osmolarity fluid. Fluid, and you should not be given that.
Yes,
that's a bad medicine.
That I agree.
Okay, so that's a good idea. So we'll try that, if that possible, to give him some fluid as the outpatient, because I have to see whether how bad is cardiomyopathy. You have to check his echo, how much he can tolerate. That actually will help him to some extent, not only decreasing risk for his kidney stone, but also probably his kidney function. Okay, this is another problem case I have. This lady, she's 74-year-old, And she has been my patient for a few times, and sometimes she again disappears and comes back. She's 74, and she said she started kidney stone forming in her 50s, not before that. Okay. So she has kidney stone for almost 20 years. She has very high uric oxalate level. She has previously many times done 24 hours by her urologist, and 70 to 130 range. I have not seen anybody this high or more than 60 unless patient has primary hyperoxaluria. Okay, which I don't have luckily any case, and have not dealt with this other than my fellowship had one case, but it's not since then, which was a long time ago. So actually we did genetic testing for primary hyperoxaluria, which is negative on this patient. So when you have a high oxaluria, there could be two main reasons. One is like if patient has primary hyperoxaluria. If that is not the case, that it's almost certain that patient has enteric hyperoxaluria. If patient has Crohn's disease or any GI condition which is leading to increased absorption of oxalate. But this patient does not have anything like this. So her past medical history is she has AFib, diabetes, fibromyalgia, history of gout, hypertension, obviously kidney stones. Past surgical history is a cholecystectomy, hysterectomy, and she had joint replacement. These are her current medication. I would tell you that she has very high urine calcium level also. So I have put on high dose of chlorothalidone. She is on Lyrica, digoxin, diltiazem, allopurinol, fipronolate, Singulair, and Trajenta. And she's on warfarin. I don't know why she's on warfarin for AFib, but why not Xarelto or something else? But I think she had some reason that back on warfarin. And which I did not know whether she has the primary or enteric hyperoxaluria. I have put on vitamin B6, which is a pyridoxine, 200 milligram BID. And recently I put her on potassium phosphate, also because of hypercalciuria, which has actually helped her. This is again not recently. In the past, this last time she had 24-hour urine. You can see that her risk for calcium oxalate stone is very high, and her urine calcium was high, like 477, very high, 397. pH, because of she's on citrate, pH is 6.5. Oxalate is 130. I never heard this thing unless patient has primary hyperoxaluria. She's getting high dose citrate, so citrate level is pretty good. She has some risk, but not that high for calcium phosphate stone. Uric acid is low. So I don't know why this patient has. I mean, luckily, even with that, clinically she doesn't look like she has a primary hyperoxaluria because she is 79 and kidney function is fine. Her creatinine is 0.8, which is a bit surprise. And she started forming kidney stone later in her life, not like a primary hyperoxaluria patient who started forming very early, even with the type 2 and 3. So clinically it doesn't look like she has primary hyperoxaluria. Then we find out, try to find out why she has. She has no significant GI issue, which would make her increase absorption of oxaluria. So here we are. What to do, and any suggestion?
Did you check her stool for fatty acids or bile acids? Sometimes I've seen patients with chronic indolent pancreatitis developing this. I had one patient that had unexplained hyperoxaluria, recurrent stone former, and he was found out to have again, but he was intermittently alcoholic. But his pancreas levels and amylase lipase and even they were all normal, but he had high bile acids, and we actually we caught it late. So we did put him on, I think, what did you put him on? Penzymes and enzymes.
Yeah,
and
cholestyramine. Yeah, okay.
cholestyramine. Yeah.
Yes.
And but he kind of stabilized afterwards.
So
But
you're
we actually
absolutely
caught him in C35.
That's good. I did not do that, but I will definitely do that. I think I kind of believe that she does not have any enteric reason to have that high. This is not like a little bit high. This is very high urine oxalate level, very high. Okay, and although she has no history of it, again, not a bad idea. I think I will do that. So thanks for your suggestion. I think not a bad, good idea. Then I sent her to a very good nutritionist. Okay, and she went over all her diet and everything, and she couldn't find any high oxalate diet she's taking. She said she takes herbal tea, and she looked into that 1 cup in the morning, and that particular herbal tea has low oxalate level compared to even black tea. So we cannot blame her for that either. So basically what she's on now, I mean, she basically for calcium, she is on high dose of thiazide diuretics. She has chlorothalidone very high, and she has history of some heart disease. She goes to her cardiologist, and many times he has changed from thiazide to Lasix. Okay, so I actually called him. I wouldn't say that I shouldn't be age discrimination. I'm also old, but he's even older than me, and he just doesn't get it that, okay, Lasix is not good for her. That increased hypercalciuria. Actually, he keep doing that. I spoke to the patient. I said, you either keep him or keep me. Okay, I want to change this guy. And she actually changed the cardiologist. In the same group, younger one, he could understand that Lasix is not, and she doesn't never been so volume overload, and he does not understand that Lasix increased calciuria, I mean high urine calcium, and thiazide. There's a reason for that, and so on that, actually calcium came down. This is older. I will, if I actually the one time her oxalate came to lowest to 60. So I'm wondering that I looked at it, this recent study that basically, if that we rule out that an enteric, there is some rare patient who because the oxalate comes from dietary source and 50% like a production, I mean, from the liver in normal people also. So maybe for whatever reason she has, even without primary hyperoxaluria, she's just liver producing more oxalate. So recent I saw this paper which said that lanthanum carbonate, which is we used as a phosphorus binder in a patient that can decrease the absorption of oxalate. So at this moment, I'm ready to try anything if she can take it. They describe 4 or 5 patients, one of them on dialysis with the primary hyperoxaluria, one with the normal kidney function, and significantly decrease their urine oxalate level. So I'm ready to try that if our insurance and everything proves that there's no other drug interaction. I'm able to try this. I don't think there's too much drawback on that using that. I'll see how it goes, whether that decreases her oxalate levels in the urine or not.
Very interesting.
Yeah, I mean, definitely, I will 100% make sure that I will check that any malabsorption. I mean, I'll rule that out. She has a good GI. Actually, recently she had some GI bleed and she had colonoscopy. Didn't found any. I'll talk to our gastroenterologist, which is a very good one, and I'll ask him that whether he has any suggestion to rule out she has any malabsorption or not.
Because we see a lot of oxalosis.
Okay.
I mean, I'm surprised that you don't. Like almost every week, we have 2 or 3 new patients diagnosed with primary oxalosis.
Yeah, we'll be lucky actually. Are you using this medication? I mean, what is
No,
that?
actually, we don't have any choice, anything. I have never not seen this lanthanum, and I'm not sure if it is even available here or not. But I'll look into this too. However, and this 130 oxalate is not a very high level for us.
Oh, really?
Yes.
I have not seen more than 60 or 70 in my patient. This is the highest I've seen. Okay.
No. Oh, you'll be surprised. There'll be like 500s and 600s.
Oh my goodness. Seriously,
So
you guys.
the real oxalosis ones. You know, our cutoff for ESRD patients who come with stones, and for them, even for us to suspect oxalosis, we have used the serum oxalate level, plasma oxalate level. The cutoff is 90.
Okay.
So, so after 90, like 130, 150, 170 is usual, and then we then check these genetic mutations, and they come back negative, and we do transplants. So in ESRD, yes, with very high oxalate levels are usual, but patients with oxalosis and functioning kidney, yes, serum oxalate levels are very high, are much higher than 130s, usually in 200s.
Again, my knowledge is I have to confess that limited. I never did that serum oxalate level on her. I mean, never checked any utility of that, checking that, but you check that regularly, right?
Yes.
Okay. Do you use vitamin B12 on this patient, pyridoxine?
Pyridoxine, yes, only in cases where we there is in the 24-hour metabolic profile, we see higher oxalate levels, not as high as this, but the citrate levels are not that low. Oxalate levels are a little higher, and they are stone free. And once they have made the stone and we've removed it, and then we check their profiles, and with this kind of scenario, then yes, we give them pyridoxine as a metaphylaxis to avoid recurrent stones.
Okay, so the other question is why patient has such a hypercalciuria? So that's another question, and
Hypercalciuria is this? I think this whole problem is the gut. Is it enteric increased absorption of calcium from her gut along with oxalate?
So I was actually, she had in the beginning, let's talk about her calcium. Okay, she had in the beginning, didn't have any high serum calcium, and we checked her PTH and vitamin D level. Everything was nothing suggesting anything. Okay, so then I put her on thiazide diuretics, high dose, and then her serum calcium increased. Okay, to almost 11. Because I put on high dose. Then her PTH was low. We ruled out, make sure that she has no, melanoma, multiple myeloma, thing like this. Everything came back negative.
PTH, how much was her PTH?
In the beginning, PTH was normal, like a 30 something, around the 30.
30 something.
Yeah.
Because a little, you see, how I have learned this is that with this idiopathic hypercalciuria, where you have normal PTH and vitamin Ds, and you have just higher calcium levels. So it is again, idiopathic hypercalciuria can have two origins. One is either the gut is absorbing more than it is required, more calcium than required, or the kidney is not able to reabsorb enough calcium. Okay, so these are two, either renal origin or enteric origin hypercalciurias. So if you give thiazide to ones with renal origin, then their serum calcium will go up. Make sense?
Okay. Yeah, so yeah, you're right. So your point is that basically, this is very common. So basically, when you have hypercalciuria, there could be three reasons. One is if your patient has a primary hyperparathyroidism. Okay, obviously in that case, your uric calcium will be high, your serum calcium will be high, PTH will be high. So that's not in this case.
Yes.
The other is causes like you have high urine because of increased absorption from the gut. Okay. Or there's a urine leak, okay, from the urine. That's caused that.
Yes.
So if you go by increased absorption, in that case, as I described last week, that those patients has increased receptor for vitamin D. Okay, so that's they for some reason they increase absorption. Okay, that increase your urine, and also because of that, your PTH actually can go down a little bit. So treatment for that is, what could be mixed picture most time it is. So treatment of that is giving patient phosphate. That's why this patient is a potassium phosphate I put her on. And actually that decreases her urine calcium. What it does, because of phosphate, it decreases the absorption of calcium in the gut. At the same time, it decreases the activity or level of vitamin D. Okay, and that's what it caused decrease the calcium absorption. So that's why I learned this like this thing a bit later, but I'm using it now. Those patients I have suspect that they have increased the absorption rather than leak, then they should be given potassium phosphate or sodium phosphate, depends upon patient kidney condition and potassium level. And also what happened that when patient has increased leak or from the urine, the phosphorus goes down also most of the time. And when the phosphorus goes down, that increase the stimulation of vitamin D. And vitamin D high level, increased activity, increase the calcium absorption also. So if you replace the phosphate, that will not increase the activity of vitamin D. So I have seen that this is a good learning curve for me and a good experience. Start using potassium phosphate or sodium phosphate on those patients with hypercalciuria.
And those renal origins would have a higher PTH level also to maintain that normal serum calcium level.
Okay, yeah.
And that's how we differentiate them between enteric and renal.
Okay.
And the cutoff that we use is 30 is that normal PTH level. So 1.5 times 30 is around 45. A PTH of 45 means that idiopathic hypercalciuria, it's not, it's probably of renal origin.
Good. So you're making it simple. So if patient has a high PTH, that means patient has a urine hypercalciuria. If PTH is on the lowish, that means it's more like enteric, right?
It's enteric. With normal serum calcium.
With normal serum calcium. Got it.
If the calcium, serum calcium is high, then it's primarily hyperparathyroidism.
Yeah. Do you use this phosphate in patient who has enteric hypercalciuria? Or...
This first time, it really makes sense. But this is the first time I'm listening to any such therapy. I've attended quite a few lectures in conferences about stones. One person, I asked him about this idiopathic hypercalciuria, how you treat it. And he also was like, we don't know. Okay, this phosphate makes sense, yes.
So I have two, actually. I looked into it, but I didn't have nobody who did. So I said, let me try because it was described that it works, and I'm using it works. The other thing which I think this patient or another patient, actually, that patient has very high urine calciuria. Okay, so that patient is on two medications for that. One is thiazide and amiloride. Okay. So combination of those that helps two ways. One is that amiloride decrease the risk for hypokalemia, which also another good thing, decrease the urine citrate. And also it does decrease the actually synergistic effect, decreasing the urine calcium. So Yeah, this is actually just to know that it comes in this medication for 500 milligram tablet. And I looked into 500 milligram tablet has about 3 millimole of phosphorus and about 4 or 5 milliequivalent of potassium. So this patient is getting about 10 or 12 milliequivalent of potassium with this dose and about 7 or 8 millimole of phosphorus. So to try this patient, and I think if they're available, potassium phosphate or even, neutral phosphate, which has sodium, potassium, and phosphate, which has even lower dose of potassium. So it might be helpful. My experience is actually positive. I don't have a lot of experience, but I have put some patient and I saw their decrease in their urine calcium.
Definitely try.
Okay, so this is one other my problem patient. Any suggestion? Let me check and chat. Any other question?
I think there was one question about the case 3. Why does patient have hypercalciuria? And I know you addressed that.
Yes, and there's so why did you use phosphate in such high dose and its current urinary calcium phosphate volume? Actually, that risk is not high, calcium phosphate supersaturation. Supersaturation for calcium oxalate is much higher. That's what we use. And this is actually, when you give milligram, that's not a very high phosphorus actually. So we have this available technology give us supersaturation of that particular urine. The risk for, and this patient doesn't have a high risk, or you have to compare which factor is more high risk. So this patient has calcium oxalate high risk, and we need to decrease her calcium. Okay. So this patient is a 34-year-old male. He has long history of seizure disorder, okay, and long history of renal stones. And he's on this medication, zonisamide. This medication also same as the Topomax, pretty much same. And this medication does cause, and slightly actually with increased frequency with Topomax, can cause a primary, or some say that a distal RTA. I spoke to his neurologist, who is very good actually. He said that he had tried everything else. Nothing worked on this patient for a young age, and he has seizure, and the only medication works, and this medication. And I do not want to change this medication. So basically, so he's on this medication for a long time. So these are his serum potassium is okay. He's on citrate. Actually, when he came, he was already on some potassium citrate, and he saw kidney stone, and he stopped going to urologist. He said, they don't do anything for me. So I did chart biopsy. I like this word. And a very long time ago, I found calcium analysis, and he has calcium oxalate stone at that time. And after that, he never had one until recently. I'm going to see that 24-hour urine. And so he had this 24-hour urine recently. His volume actually was quite decent. He doesn't drink much because he said he goes to job and he doesn't have time. He doesn't want to go to the bathroom all the time. So this is basically, you can see that he has very high risk for calcium oxalate stone. Urine calcium is not too bad. Oxalate is not too bad. Citrate, he's on potassium citrate, decent dose, like I think 40 milligram daily, and is non-existing urine sodium. But he also has risk to some extent high risk for calcium phosphate stone also. And urine pH is on the high side because he's getting potassium citrate, and he has previous history of a long time ago, almost 15 years ago, that he has calcium oxalate stone at that time. So CAT scan showed like a year ago, that multiple kidney stones, left side, right side, left side a bigger one, left side smaller one. So some calcification, well, recalcification. The recent stone analysis just came in actually. I didn't see he's coming back to me. I'm going to address that. So it has changed. So calcium oxalate stone only 20%, calcium carbonate stone, carapidite, which is calcium phosphate actually, 40%, and struwite stone. So now he has changed his stone analysis. This is not a good thing. I mean, if we're developing that. So he's mixed stone now. So the question is what is the risk factor? He has very low urine citrate. If I give him more citrate, that will increase the pH. Okay. And it's also not good for this stone and this stone. What to do about him? Should
I
we?
think his primary stone is leading to a nidus formation. Now the secondary types of stones are super added on that nidus. So something started, and whatever the secondary is on top of it. So, of course, water therapy or hydration is the strategy, but should we just focus on the original calcium oxalate first and then take care of the stones by whatever the means, surgical or lithotripsy, and then stay hopeful that this doesn't happen again?
The question is, giving potassium citrate causing more harm or good for him? Because if I see any patient with the calcium phosphate stone or even a stuwite stone, we all try to decrease the urine pH. Okay. Because if he has, obviously I have to do his urine culture now, whether he's forming any like proteus infection or not, that causing, urea splitting organism, that need to be taken care of. I will check with the urologist. I will send him to which I trust more, and he actively need to take care of these stones, which is relatively not that big right now. It's not staghorn right now, before they become one. Other than that, I'm giving more fluid to him, asking him, because he doesn't drink. I mean, he's kind of stubborn. Sometimes even at this age, sometimes he comes with his mother and father because he's like a child, like he's 34-year-old. So obviously I will tell him that he has to drink more fluid. But question is, this is the question. My question is, should we continue his potassium citrate to cut down, make it more, because he has risk for both calcium oxalate and calcium phosphate.
I think one of our professors studied these strowite stones in detail, and these, the way how the percentages you had shown, there was 40% of strowite, and then apatite, and the other magnesium, all these salts. Usually they have this matrix, this organic matrix, in which all these other precipitate, all these other salts precipitate. And the initial formation of that matrix has to do something with that deficiency of natural stone inhibitors that we all have in our urine, like all these Tom horsefall proteins and there are other certain organic things in the urine. And it could be something of that sort that predisposes this gentleman to have these kind of stones. Some deficiency of natural stone inhibitors in his urine. And I don't know if we can do anything about it. We can do all these routine things. We can increase the volume, address the citrate and all that. But these multiple, precipitations has to have a nidus first.
Yeah. So you think this medication is something to do with this zonisamide? I mean, this typically looks like a patient with the RTA. And so when you have, I mean, I never had, only way to check whether he has normal serum bicarb level now, but he has been on potassium citrate high dose, probably from that. I don't want to take him off and check it again, but I think doesn't make much sense on that. But I know when you have metabolic acidosis, that increases your citrate absorption from proximal tubules and decrease the urine citrate level. And treatment for that is potassium citrate or even sodium bicarb. His serum bicarb is normal. I don't know whether that makes sense giving us oral bicarb, but it's the same thing. If I increase his urine pH more, which I think not a good idea right now because he has, the Stewart stone and some calcium phosphate stone now. So basically, what I could do, I think that in this case, when I have this kind of question, the common thing is calcium. I mean, at least two of these. So whatever I can decrease urine calcium, previously urine calcium was high. Actually, I put him on, maybe right or wrong, I put him on thiazide diuretics because he has, that what I looked at some literature that what to do. They said decrease the urine calcium as much as you could. So his urine calcium is 212, before that it was actually higher. So if I decrease his urine calcium by giving him thiazide diuretics, maybe some help, if I cannot help a lot about that. Is that a good idea or won't be a good idea?
No idea.
Yeah. So just like, that's why I say there's still a discussion. I mean, that's why calcium stone patients are sometimes very difficult to deal. You never know. You do one thing and you say, okay, the other thing doesn't make sense. So you try your best. We have a limitation of our knowledge and in this, and we just do whatever best we can do with this patient.
I mean, if I'm you, I will focus on the calcium.
Well, that's what I did. I mean, just last visit, I mean, I called him, I said, okay, start taking this. I put him on indapamide, 2.5, and now he's coming back, and I will tell him that go to a urologist, which he stopped going. And I spoke to his urologist again. I said, any way you can change to different medication? He actually, we discussed a lot. He said, believe me or not, I tried everything, and I knew this medication can cause some problem, but didn't work. So I hate to going through the seizures. Stone or seizure, I mean, option is seizure is not a good thing to have. Okay, so so the question was that I recently, found out that if you're a patient with the hypercalciuria, so and patient has many of them, they come on, they're taking vitamin D because of now there's almost a kind of fashion there to check vitamin D for good reason. Everybody check vitamin D level, and everybody has low. Very few patients I've seen, not patient only, healthy person. In my own, my low when I checked last time. So giving vitamin D. So if patient has high urine calcium, will you give vitamin D or it will stop you? Will it stop or not? What to do? If vitamin D level is low.
I think you have put it very mildly that, these checking vitamin D levels for good reasons is okay, but I see a lot of times it's not for very good reasons either. They just do it. Like I see a lot of people bringing in reports of vitamin D with obvious clinical osteoarthritis, knee pains, and in their 40s and 50s with low vitamin D levels and getting vitamin D injections and drops and all of the replacements of all sorts. I personally, I may be very wrong, but I don't think that, the limited knowledge that I have is that vitamin D analogs are so many, and there are the ones that we check probably do not reflect the exact the division of which analog is which, how much. So the reference ranges of vitamin D values may be different for different individuals, and it may not represent a lower vitamin D level actually in that person if they do not have any symptoms related to vitamin D deficiency. So I usually, other than CKD patients for their bone mineral metabolism, I don't check routine vitamin D levels. And even if they come low, if they come, and even in my family, if they come and ask me that the doctor has asked us to take vitamin D levels, I said, you decide. If it were to be for myself, I would never take it.
Yeah, I mean, basically, this is thing we're talking about. Nobody knows what exactly the answer is. So we just use our best knowledge. And I agree with you. Actually, when I check my vitamin D level, I see my primary care doctor went for my annual checkup and I want to check your vitamin D level, especially COVID days. I mean, everybody was checking vitamin D. I said, go ahead, do it. And came out a little bit low. It was winter, but I didn't take any vitamin D. I said, I'm okay. Why I would take that? But again, those patients we see who have low vitamin D level, we check like 25 hydroxy vitamin D level. And it's low mean that they're like 10, 12, okay, and they have high urine calcium, and they have at least high risk for osteopenia or osteoporosis. In that case, what I search, they said that there is no risk of giving vitamin D to those patients, okay, orally at least. And if you are too cautious about that, you can check urine calcium before and after starting vitamin D level, which I have checked a couple of times. I did not see any change after recently, high doses of vitamin D level. What happened that if vitamin D level is low, and that actually can extract more calcium from the bones. So that is one way to, in a way, it decreases urine calcium level also if you replace vitamin D level on those patients. But again, the other question comes that how you check urine calcium. It is just by doing 24-hour urine calcium, or you have an idea, random urine calcium creatinine ratio can give you an idea. Anybody has any experience in that?
Yes, I think this spot results are available right away on the spot sample. And I think I've seen some correlation studies that the ratio of 0.2 is normal. It's the upper range. It should be less than 0.2, and higher than 0.2 is high. So
what I have done recently, you just do random urine calcium and random urine creatinine, okay? And you check the same way, like you put random urine protein creatinine ratio. So you put protein and replace it with the creatinine and with the calcium.
Right.
That gives you an idea that how many milligram of calcium per gram of creatinine you have. So in my opinion, if you have less than 200, okay, so you have an idea that how much calcium in the urine patient has. So less than 200 that you desire, then patient is good. Or you can see that I started doing this. Every time I order a 24-hour urine test, I order random urine test also, calcium, and see whether that correlate or even close or not. So I don't have so many cases right now. I can say that, okay, it works or not, but I will have a better idea in coming days because I just started doing that. But I think this can be done, and hopefully this prevents you for that problem of doing 24-hour urine calcium to see patient respond to that. So the other question is, the patient has history of osteopenia or osteoporosis, and then this bisphosphonate, like Fosamax and all those, that helpful or not helpful, or should be given, should be continue, or should be ordered? Any suggestion, any experience, anything you read about it?
I'm sorry, can you repeat the question, please?
You know that patient who has osteopenia or osteoporosis, and they have the hypercalciuria. So if you give that bisphosphonate, like the Fosamax or what you have bisphosphonate on those patients orally or even injection wise, that will helpful in this condition, decreasing hypercalciuria, or will not make any difference or increase the risk for that.
Yeah, I don't know. I really have no experience in this.
Because commonly patients are taking this now, the Fosamax,
Usually.
bisphosphonate, and they will ask you, should I stop it? Should I continue? Or because here is, I don't know in Pakistan, but here in like Farooq, what's your experience? There are a lot of patients on that, right? Elderly patient or middle-aged patient on these medications.
Yeah, I haven't encountered this question or addressed this.
So I had looked into it because nowadays the primary care doctor, which unfortunately they don't have left much to do. I mean, everything goes to specialist. So in a good way, they check all these kind of things. The risk for osteopenia and all those things, and they very commonly patients are put on this bisphosphonate. So I looked into it. There is actually more benefit, and there's no significant risk if patient has risk for osteopenia and patient has hypercalciuria. Only thing is that I think there's a gray zone is that when patient has advanced kidney disease like stage 4, stage 3, and that there are different opinions that can make it worse or kidney function or not. But unless patient does not have advanced kidney disease, there is no risk or maybe some potential benefit of those patients having bisphosphonate. Okay, so the question is, what is your practice in treating a steroid stone? I mean, medical treatment as hydroxy and hemisurgery in written books. Is there any practical experience besides surgery? Fortunately or unfortunately, I don't have actually. I did have one patient. We put that patient on this medication along with surgery, and that AHA. That actually patient on steroid stoned. This medication actually prevents the formation of ureas or splitting ureas. And two patients, I remember that. One had a lot of side effects and she didn't want to take it. Okay, gut issues and all those. Those patients are not with me anymore. I'm talking about a long time ago. And in one patient who continued to have this medication, it did work. But steroid stone, the main treatment, medical treatment, is that to make sure that the patient has the urine is clear of infection. Patient are on suppression therapy. Once the active urine UTI is taken care of, patient should be on suppression dose of antibiotics like Bactrim, not the treatment dose, suppression dose, nitrofurantoin or Bactrim. And a couple of times we took the patient off those after 3 or 4 months of continuously negative blood urine culture, then we taken off. But otherwise, they stay on this medication for long-term basis. It does help.
I think Dr. Ali Ashraf, he has a case to present.
Yeah, definitely. Please go ahead.
Ali?
Let me just unshare my, so we can done with my.
Hello, yeah, let me share my screen. I actually, it's a case that I'm also baffled with, and I need some expert opinion.
Just to add some personal thing, Dr. Ali Ashraf and I, we are both class fellows from the med school.
Oh, he's a young doctor. Okay.
He is, and then he moved back to Multan. So he is serving the motherland, and he spent a lot of time in States after fellowship, and now is back home. So we are very impressed. We are very happy that he's back home.
I don't know who's serving who, but I'm back.
We'll figure it out.
Yeah, I cannot share my screen. Can you allow me?
Oh, sure.
I know he's obstructing you.
Actually, I cannot anymore.
No.
Okay, just describe that. That's
Dr.
fine.
Lainwala,
Acha, okay, let
you are
me
the big
describe
boss
it.
of Zoom.
So I have a 38-year-old
me.
guy. I saw him it's been going on for almost 6-7 months now. So he's a 38-year-old guy, diagnosed diabetic, hypotensive, persistently hypotensive, like in the 90s and 80s. And, we have a lot of issues with Hakim medication, but he's not taking any, persistent adrenal insufficiency type, but he's not taking any. And he's a recurrent stone former. He presented to us with one time with a obstructive uropathy. He had like 3 stones lined up in his ureter. Creatinine was 4.3, was hypotensive. We thought that he was in pyonephrosis shock, put in a stent, hydrated him. His bicarb was 14, lactate was high. So he was also taking vitamin D for, generalized weakness. Everybody gets vitamin D injections and multivitamins like Cerbex and stuff like that. So we treated that. His creatinine came down to around 2.4 and then kind of settled there, but his persistently was acidotic. Bicarb was like 16, 18 at the most. Ultrasound of the kidney showed nephrocalcinosis all the way throughout both kidneys. And in addition to that, he was also having, these 3 stones in his PUJ on the left side. So once we thought that, okay, it was vitamin D related, plus minus his PTH at that time, we should not have checked it in acute kidney injury, but it was 1149, very high. So we thought that we got that, clinched the diagnosis, probably as nephrocalcinosis from the hyperparathyroidism. Stone analysis actually was completely offsetting. His dialite stone was 90% composition and struvite was 10%. So it was all, calcium, struvite and dialite. With the renal tubular acidosis, we put him on citrate, potassium citrate, and also did an ENA and ANA anti-dsDNA panel. And his ENA panel came back positive SSA and SSB. ANA was negative, anti-dsDNA was negative, RA factor was negative, complements were normal. So his ACE level was also within normal limits. So, okay, we thought that he might have some mixed connective tissue disorders. He also had HRCT done at that time that showed a picture of GGOs, which is suggestive of peripheral interstitial lung disease. Refused biopsy. Also, I have never done a biopsy on a nephrocalcinosis patient. I don't know whether we should do it or not, or that's another question. But we actually put him on potassium citrate. We also put him on steroids, and then and that actually did help his hypertension a bit. And then we've put him on Celsep, para rheumatologist, for this Sjogren syndrome. He did okay for a while, but every 3 or 4 months he's continued to make stones. And every time we checked it twice already with his stones. They're all the same composition. And his urine pH actually stays around pH of 5 and 6. It's not very high that you would say that, he's probably getting recurrent UTIs. I mean, he has some leukocytes at times. I've treated him multiple times with antibiotics also, but he's not behaving like a recurrent UTI. I understand that his diabetes is not under ideal control, but his last A1C is also not very bad. It's like 6.7%. So my question, we actually did a 24-hour urine on him. Creatinine had settled down to around 1.3 to 1.6 after we started Celsep. His bicarb actually improved to 22, and his urine pH again between 5 and 6, so it wasn't that bad. We thought that we kind of corrected him. His 24-hour urine volume was 3.4 liters. Urine 24-hour calcium was 202, and 24-hour oxalate was 46, which is actually low. Urine citrate was in the medium range, was like, I think, 120 or something. I'm not exactly sure. Urine sodium was 110. Urine uric acid was 642. And his serum uric acid at that time was 5.7, which is normal. So, you know, I'm still, I thought that he probably has hyperparathyroidism, and his urine, we actually did a 24-hour urine was not very high, but his PTH was very high. So I did a DTPA scan on him, but that came back absolutely normal. I also discussed with one of my local ENT guys, and he said if because it's absolutely normal, he doesn't do ultrasounds and he's not convinced about whether this is hyperparathyroidism. Then I checked his PTH again, and it had come down from 1149 down to 311. So, which is still high, but he also has CKD now with a creatinine of 1.6. And his diabetic also has some, subnephrotic proteinuria around 500 to 800 milligram per day. So my question is, what to do with him, how to treat him.
Let me start the discussion. Okay. First of all, I'm happy that he's not my patient. not very easy. Okay. Anyway, so first thing that let's go one by one. First of all, why he had this high PTH. You will never see a patient. I mean, in my experience, now I'm not the authority. I'm just in my experience. I have never seen a patient with primary hyperaldosterone with this high. Okay, unless patient has like adenoma or like cancer or something like that. Okay, let me stop here. I mean, anybody has any experience of that, like primary hyperparathyroidism with that high PTH? I mean, at least I not even close, not even close.
Not even close.
Yes. So PTH, we have primary goes like as 100, 102, 150, things like this. And if this patient has no adenoma, we have to question whether this patient has secondary hyperparathyroidism or primary hyperparathyroidism. Right?
Or tertiary one.
Yeah, even tertiary. Absolutely. Yes. So that's the one thing. Okay,
and
so
serum
then
calcium was high throughout or normal throughout?
Serum calcium was like 9.6. I checked it twice, 9.6 and 10.1, but our upper limit is 10.5. So that, twice it's fallen in the normal range.
So sounds like
goes in favor of secondary, because if he would have that high primary causing that high PTH, his calcium would have been 13, 14 at least, if not higher. I mean, so if he has normal calcium level, this high PTH, so it sounds like more secondary or probably tertiary hyperparathyroidism.
But I mean, still high, it's 311. And, we checked the vitamin D level, the name was like 26. Okay. And he was already on vitamin D replacement, which I stopped, thinking that this nephrocalcinosis is probably secondary to, but his serum calcium came back okay. The other thought I had was maybe it's Sjogren's syndrome leading to type 2 RTA, and that leading to, hypercalciuria and nephrocalcinosis. And we are treating him, but he has not, usually with nephrocalcinosis, when you have medullary sponge kidneys, you do not keep forming stones. He's already getting treated for that.
I mean, if you have primary hyperparathyroidism or RTA, almost all the time you have calcium phosphate stone and high urine pH. Okay. The only thing, if you make a bit simpler, is that his urine pH is not high. Okay.
Yes.
In that case, the treatment you need to give, you have to be more aggressive, giving potassium citrate or bicarb if you already have given, because his urine citrate is very low. You said 120 something, which is very
low. Urine citrate is low.
I like to have his urine citrate close to 1,000, in this range at least 800 or 1,000. So you need to give a tons of potassium citrate. If potassium, keep an eye on his potassium. Obviously, he has CKD. You cannot give too much, or you have to find some other way to give him citrate. Although at the expense of giving some sodium, like sodium citrate is there availability over there, or even calcium oxalate, potassium, calcium citrate. Or just giving more bicarb, like a sodium bicarb, because you have, when bicarb, increased serum bicarb, that decreases the citrate absorption from proximal tubules, and that put more citrate into the urine, and that's inhibitory. So I'm glad to make some to how simpler. He doesn't have high urine pH. That would make things really difficult to give him. So right now, what I would do on this patient, giving whatever limitation I have, how much potassium citrate, or anyway, citrate can be given, or given more bicarb to the extent that he can have a little bit metabolic alkalosis, like at least less than 30, but 28, 29 range is okay. Other than that, I think he has a secondary hyperparathyroidism, and that actually extracting more calcium from the bones. Okay, so you need to find out whether how you can treat that. How is the phosphorus? Is it normal or high?
Phosphorus has been in the 3.5 range.
High.
2.8 to 3. Our lower limit is 2.5 to 4.5.
Yeah, it's actually it's not
It's
high.
on
So
the lower end of normal. But again, the PTH DTPA scan was, I mean, not DTPA, sorry, SESTEMIB scan was completely normal. Again, and this was done from Nishtar, which is the only place we can get it done, and this is considered to be good center.
No, you have to believe that. Okay.
What about nephrocalcinosis? You think it's a secondary phenomena?
It is. I think. I don't know. I mean, nephrocalcinosis. He probably had increased calcium going to the bones. Okay.
What about his positive SSA, SSB? Sjogren's physiology plus the HRCG suggestive of interstitial lung disease, which actually, kind of stabilized since we put him on Cellcept and prednisone. Prednisone is low dose because, of his diabetes.
I mean, I think it's Sjogren's that it can cause a distal RTA or a primary proximal RTA.
Distal RTA.
Yeah,
yes.
distal RTA. So that again, this is basically most of the time they have high urine pH, and also they have more calcium phosphate stone, and in this case. But I think that the problem is that these patients, they don't read the book. Sometimes they don't go according to what we're expecting them, but we have to go whatever knowledge we have. But again, I think this patient has very low urine pH, and you need to increase his urine pH and treat his bicarb level. And if Cellcept helping, I think that probably will be helped. But you need to do something about his secondary hyperparathyroidism.
Yes, and he persistently remains hypotensive, like in the 80s and 90s. That also I cannot figure out. I've ruled out adrenal insufficiency on him.
That's again, we need to talk about that. But I think what you can do on his, you have Sensipar or calcium. What's the?
It's expensive, but it is available. It's it is available. But again, for secondary hyperparathyroidism, would you really recommend it for secondary?
Yeah, of course. But Farooq, what do you think? I mean, any others? I mean, we will do all the time. I mean, as long as calcium is not low, and especially which is not low.
So to me, it looks like that whatever the Sjogren's physiology is, that is a contributing factor. So, and then what we can modify or alter is the fluid intake if you can control his PTH, and treat his Sjogren's and keep giving him water. So whatever you can use to treat PTH, in this case, this is CKD, Sensipar might be indicated because of the, you're seeing the other side effects, stones and etc. So I would try something, because option of not doing anything is it's sooner kidney failure, and whatever you can delay, that would benefit the patient.
Okay.
I mean, if you can afford Sensipar, I mean, there's no.
Sensipar is expensive, but yes, it is available. What about bisphosphonates in him? We can monitor, but his phosphorus might drop. I think it's already lower normal kind of a thing. But yeah, I can monitor that too.
I mean, bisphosphonate, what's the creatinine again? It's 1 point?
1.6.
It's already at the borderline, that it's gonna go below 30 very soon. So
I think in this case, I mean, this is a patient who you have to try something. Okay, you cannot be. You have to see pros and cons on this. Everything you do have some cons, but you see more pros and then cons. I think there is some potential benefit of giving bisphosphonate also. That's not should not be that expensive, right? Compared to Sensipar.
It's Sensipar is very expensive.
Expensive, I know. Even the
It's
hair
like
patient, they don't
almost-
take it unless the insurance covers. Very expensive.
We don't have insurance.
No, in Pakistan there's no insurance, but so that's some that is very expensive. So if he cannot afford, he cannot afford. I mean, but I think bisphosphonate could be. But again, the one thing I would definitely do more bicarb or potassium citrate.
Okay. Yeah. That's good. Thank you. That's give me some direction.
Yeah.
And
Get his diabetes
monitoring
under
the
better
patient.
control.
As well. So,
Thank you.
all right, it's 1:43.
Well, yeah, I just wanted to answer this Mufti Baligur Rahman's comment. Well, here in Pakistan, again, I've tried to convince two of our ENT surgeons to do a parathyroid ultrasound on him, but they have both refused. They said if it's the SSTBB scan is absolutely normal, there's no way we are touching him. He doesn't have adenoma, or you want to get us to take all this again. I couldn't convince. I have seen cases that had normal SSTBB in America that had turned out to have small parathyroidinomas or even hyperplasias. We get that done, but the clinical picture in his case, again, with the normal calcium and normal phosphorus plus minus, and urinary calcium also not very high, 216, 202 was the 24-hour.
Do you trust that PTH level, you think, or that
1149 was actually for Chuktai lab, and it's considered to be a decent lab.
Surprise.
And again, and again, repeat was also still high, 311, which is still significantly high, and he's a tall guy. He's close to 6 foot.
I mean,
creatinine 1.6 is close to 30, 35 for him. Still 3B, CKD3.
That high secondary hyperparathyroidism, unless patient, end-stage kidney disease, phosphate all the time high, and a thing like this, not like patient with CKD. So Dr. Kesselman his hand. So,
sir, thank you very much. Dr. Ali, your patient could be a diabetic nephropathy also. The creatinine 1.6 may be due to diabetic nephropathy also.
Yes, he has proteinuria. Yes, he has proteinuria, and that's why I couldn't give him a lot of potassium citrate, because he's also an ACE inhibitor, and hyperkalemia I'm always worried about. He lives in a rural surrounding. He comes, sees me every 3 months, so is not very reliable regarding low potassium diet and everything. But I think I can probably give him more bicarb.
And how about thiazide diuretics?
Thiazides, I have not tried.
The advantage would be on that case. First of all, it will increase bicarb level. Okay. The other thing that it will allow you to give more potassium citrate. Okay. And I don't know how his calcium is okay, right? How is calcium?
Yeah, 9.2 to 9.8 in that range.
No, I mean urine calcium.
Urine calcium was 202.
Okay, and luckily his serum calcium is not already high, and also that probably will helpful for his bones also, because of which is probably affecting because of hyperparathyroidism. So I don't think any risk of adding
thiazides. Okay. So he's diabetic since 6-7 months ago. He came to us, and he was diabetic at that, and that to answer Dr. Hina's question.
So thiazide will help him with his ACE inhibitor,
okay.
also decrease some proteinuria. So it's a lot of benefit of giving him thiazide diuretics.
Okay, got that. Thank you very much, everyone. So
there is another question. Sorry, excuse me. There is another question. When the patient is above 65 or 70 and he or she comes with the high creatinine with proteinuria, we should start with ACE inhibitors, ARBs, or we should not, because sometimes it increases the creatine level in the body.
I mean, that's simple. I mean, in my opinion, there's no contraindication, even patient 100-year-old, okay. And when creatinine increases, not because of nephrotoxicity, because of probably, we know why potassium goes high. I mean, if you keep going high, we slightly like 1.8 or something, slight high, 30%, 40%, you don't have to worry about it. If you keep going high, you need to hold on for the time being and check the dose. Eventually, in the long run, a patient who is not on ACE inhibitor or ARBs, his prognosis about kidneys are worse than compared to a person who is on ACE inhibitor ARBs. So I don't see any age limitation on that. That's my opinion.
Okay.
Any other question, or should we wrap it up? Dr. Farooq?
I don't see. I think we can wrap it up.
Yeah, I think we don't have any questions. Okay. And thank you, Dr. Nawala, and everybody else. I mean, we definitely, that's what I like this discussion, because we learn from each other. You have different experience, we have different experience. And I learned definitely new things. And
we did.
Okay.
And we
Great.
all did.
So everybody,
Okay. Thank you. Thank you. Allah Hafiz.
Thank you very much.
Allah Hafiz.
Allah
Allah Hafiz.
Hafiz.
Yes.